Hi, my name is Vincenzo Berghella, and it's my pleasure to co-host this session on cesarean delivery techniques with Dr. Michael Stark. We have a lot to cover, so I'll get right to the point. I thank Dr. Di and Dr. Romero for having us here at birth. I will talk first about preoperative care for cesarean delivery, but the first thing I want to say, it's a personal note. This is my father and my original family with my mom, my sister, my brother. My father was an obstetrician. He passed away last year. And he talked about the Stark technique all the time. He talked about Dr. Stark and how you doing, Stark? He didn't speak in English, so he would say, Fai Stark, come la Fai Stark. And the Stark name for the last 20, 30 years has been ingrained in my brain. Again, makes me remember my dad, and I'm very honored. And I think from above in the sky, my dad will be very proud that I'm here with Dr. Stark. So again, an honor for me. I will talk about evidence regarding, in this case, the delivery by C-section, and I have nothing to disclose. Cesarean section obviously is very common. There are over 4 million in the US. Over 30% cesarean section rate. Ours at Jefferson is about 28, 29%. And obviously in the world, even more common, as there are almost 145 births, it's estimated that over 30 million cesareans are done in the world. So it's really important to do them correctly, since this continues to be the most common major laparotomy in the world. And again, there are many randomized studies, and there's a lot of experience that Dr. Stark will go over, but there's also a lot of evidence that we and others have published in books and many reviews, including in the American Journal of Obstetrics and Gynecology, the great journal. The incidence, as you know, it's going up. This is a Lancet article, and some countries have a much higher incidence. Some countries have a lower incidence. We really don't know the exact and best incidence, but this is what the numbers show around the world. So what should we do as we get ready to do a cesarean delivery? And I'll mostly cover a term, uncomplicated planned cesarean delivery. You can actually play music. There's evidence that playing music increases positive emotions in the patient and improves pulse rate and satisfaction. We now allow, unless there is a major emergency the patient is going to get intubated. Over 97% of C-sections are now done with the patient awake, and we can have a significant other in the room, and the mother can participate more actively with her significant family member to the cesarean delivery. Obviously, with COVID, for a brief time, we here in Philadelphia did not allow partners, but we are allowing partners again during labor and delivery, and actually doula as well. There are randomized studies on room temperature, and the room temperature doesn't make too much of a difference, except for probably preterm neonates who need to be warm, as you know. Cold does not do well for them. So I would say that this randomized evidence suggests that maybe if you have a preterm C-section, that you may want to increase the temperature to slightly higher, 23 centigrade or 73 Fahrenheit, to decrease neonatal hypothermia. Again, more important for a preterm baby. Important to do thromboprophylaxis before, during, and after the C-section. We always do compression stockings, some kind of compression device, but if there are additional risk factors, we often go to heparin for morbid obesity and other risk factors, as you see listed. You can do lateral tilt. It doesn't make too much of a difference in the neonates, but it's kind of a common intervention, 15-degree tilt. They may, in some studies that are now kind of old, it hasn't been studied recently, improve some parameters in the baby. Not necessary to do oxygen supplementation instead in the mother. This has been studied, including in pregnancy, and you can see at the bottom, I always put down the randomized control trials, the reference and the numbers. And as you can see here, there's really no benefit from giving extra oxygen to the mother. Shaving is also not necessary. It actually only causes discomfort. And while there's not much level 1 evidence, at most, I would say the clipping may be indicated in some cases. This is the newest slide that I have. I just made it the last couple of months. A new randomized studies from Dr. Stone in New York was published in the Great Journal just a couple of months ago. They randomized over 1,300 women to have what's called body cleansing at home, in this case with chlorhexidine compared to placebo clots. And as you can see, even if you clean different sites, they had no decrease in surgical site infection. This works in GYN and other surgery, so I think we need more trials, but this first trial then off did not show a difference. So we don't do it yet routinely. We do routinely skin cleansing with chlorhexidine alcohol. This occurs, again, as you can see here, Cochrane and many randomized studies showing that this indeed decreases wound infection. So this is routine for us. Tranexamic acid before we started C-section is becoming more routine for us. These are meta-analysis that we did years ago showing that 1 gram or 10 milligrams per kilogram of tranexamic acid before the skin incision, kind of at the time of the antibiotic prophylaxis, decreases blood loss, hemorrhage, and transfusion, etc. So especially in cases of placenta previa, placenta accreta, prior postpartum hemorrhage, etc., I would suggest to use tranexamic acid. The NIH is doing a large randomized study on this, and I can tell you that we have not seen any complications for the mother, no excess clots. So it's a very safe medication to use for C-section. Prophylactic antibiotics, we contributed to the Cochrane with Dr. Daniel McKean, one of our former fellows, and is now well established that we should give prophylactic antibiotic to everyone before a C-section, 30 minutes before incision. We usually use Ancef, cephalosporin. You can also use ampicillin, and we do add azithromycin for labor and rupture membrane as per a large trial published in the New England Journal of Medicine. This has also changed in the last couple of years, even since the last birth conference a couple of years ago. Vaginal cleansing is now routine before cesarean delivery. We did an original meta-analysis first with Dr. Kaisuti showing lower endometritis with vaginal cleansing. But then there's been last year in AJOG-MFM, a new journal called the Pink Journal, AJOG-MFM, a large randomized study again from the US, over 1,000 women, showing that chlorhexidine vaginal cleansing, it's even better than iodine cleansing. So we now do routine vaginal cleansing in women in labor with rupture membrane. I should say not everyone, but in labor and rupture membrane, we do chlorhexidine vaginal cleansing. And we implemented this as we were doing some of this trials. We first implemented vaginal prep, and then azithromycin, as you can see, this is Jefferson data, our surgical site infection rates went down. You could also consider, before the C-section, giving gabapentin. There are trials that show that giving gabapentin decreases visual pain scores at 24 hours of movement. This is one of our residents who published in the Renzo journals a couple of years ago. So this is something to consider to decrease pain in women, just one dose, 600 milligrams. You could also consider not putting a Foley in. There are randomized studies on this issue, and I think a lot of us are reticent and still put the Foley in patients during a C-section. If you put it in, you should take it out right away, as we'll discuss later. But I think that some people around the world are beginning to follow this evidence and not putting any Foley in, especially if it's a primary C-section and you don't think there's going to be any scar tissue. We did a meta-analysis on this randomized studies just last year, showing that if you put adhesive drapes just before you start a C-section, you actually can increase wound infection. So use drapes, but no need to have adhesive drapes. Just have a hole and prep it with chlorhexidine, like we said, and no adhesive drapes. And obviously, more people around the world following Atulka Wande and many other surgical specialties do a timeout just before starting the C-section. So just to conclude, before I give it to Dr. Stark, before delivery, I think it's important to consider having support for the woman, having a more family-oriented C-section so that she can start skin to skin right away after the baby is born. Tranexamic acid can be considered, vaginal cleansing with chlorhexidine if the membranes are ruptured and people are in labor, gabapentin for pain, consider no Foley for removing immediately after, and no adhesive drape. So a lot of changes in the last few years, a lot of evidence coming out all the time, and a lot lower complications in blood loss and in infection and pain if you follow some of these suggestions. That's all I have. I'm going to give it to Dr. Stark, who I can't wait to hear, and he can begin to share his screen, and he will go over more details about the cesarean technique. Thanks, Michael. It's an honor.
Thank you very much, Vincenzo, and also thank you, Giancarlo Di Renzo, and also Roberto Romero for giving me this opportunity. I worked, operated in many countries and visited many countries, and sometimes even in the same department, different surgeons are performing cesarean section in a different way. So the idea was to find out what is the evidence-based surgical technique, which steps should be done, which steps should be avoided. And I'm going to speak about. So these are my disclosure, no conflict of interest. And during the 19th century, longitudinal incisions were done. The first successful laparotomy was done in 1807 by Ephraim McDowell in the United States, in Kentucky. And he did longitudinal incision. And throughout the 19th century and beginning of the 20th century, longitudinal incisions were done. In the 20th century, the era of endoscopy, you can see on the left side, George Kelling, who was the first one to do endoscopy, Raoul Palmer, the French one, who developed all the modern types of endoscopy, and Karman Nezhat, who but he introduced the screen into the operation room. Now, the question, where are we going in the 21st century? Number one, we have today except the endoscopy, we have the natural orifice surgery. We are using natural opening to perform surgical performance. We all are aware about the robotic surgery, which is taking place. And today we have endoscopic solutions nearly for each abdominal operation. So in the future, cesarean section will probably be the only one without any alternative. And therefore, it's very important to analyze each step and to find out what is the best way of performance. I will introduce all of you cesarean section, which I believe should become standard procedure all over the world. At the moment, it's already nearly routine in Italy and Germany, and soon it will become also standard in China, and we hope that it will be accepted everywhere. You can see here, for example, a new article, evidence-based cesarean section for universal use in China, which was published recently, and already we got many positive responses. I started my work concerning cesarean section at the time I was working in Jerusalem. Here you can see the Misgavlada Hospital and in the old city of Jerusalem. And this was the reason why I called the operation, I called it the Misgav Ladach method. Again, in the 19th century, longitudinal incisions were done. Towards the end of the 19th century, Van and Steel in Kiel invented the transverse incision. He described for the first time in 1897. And now for many years, some people used to do longitudinal and some people used to do transverse incisions. Now, it took 74 years for the first comparative study between longitudinal and vertical incision to show the benefits of transverse incision in cesarean section. And you can see 70 years means that traditions were always very, very strong. 1972, C.D. Joel Cohen, who was my teacher, later he became a good friend, and also when I became director, he came and worked in our hospital. He was a gynae oncologist, and he had another idea about how to open the abdomen. He believes that it should be done above, as I will show you later, above the plica arcuata, and where the muscle is not adhered to the fascia, and therefore he believed it will be easier and less traumatic. And indeed, in a study which we did already in 1994, we found out that if we do modification of the Joel Cohen incision and we compare it to the financial incision, significantly lower febrile morbidity. So now, step by step. Number one, what side of the patient should, of the woman, should the surgeon stay? And I insist that right-handed surgeons should stay on the right side of the woman. Because, let's say, believe that you are a cellist and they ask you to play with your left hand. If you stand on the right side, it is easier to deliver the baby because your right hand is more sensitive. And when you are stitching the uterus, the needle will go away from the bladder and you will get less damage to the bladder, which happens once in a while. Now, how do we do the operation? First of all, we mark, as Vincenzo said, we mark a line 3 centimeters below the spina iliaca of both sides. The first incision is very superficial, cutting only through the cutis, as you can see here, only through the cutis, so practically no bleeding will occur. In the midline, where there are no blood vessels, you deepen down until you get to the fascia, and you make a small transverse incision in the fascia. Now, you take straight scissor with round tips, and you insert one blade below the fascia and the other one above the fascia, and you push it once to the left, once to the right. The scissor should be open about 3 to 4 millimeters. So you open the fascia below the fat tissue and above the muscle, and you do not damage the blood vessels. Now, you pull both the fascia up and down. You ask your assistant to put 2 fingers below the muscle, and you are pulling the muscles laterally as much as necessary. If you do it correctly, at the end of the operation, blood vessels will come back to the original place, because like strings on a musical instrument, they come back to the comeback. You can see it now, a very superficial incision. This lady is 124 kilograms in weight. So no difference whatsoever if she's a lean woman or overweight. You can see the transverse incision, which is done in the fascia. Now I'm taking the straight scissor, pushing fascia once to the left and once to the right. Now up and down, right and left. You can see here that opening the abdomen will not take more than 30-35 seconds. Again, the string we are dealing with the blood vessels as if they were strings on a music instrument. Now, here's a peritoneum. We never open peritoneum with a sharp instrument because sometimes if you're in a hurry, you might make damage to the underlying structure. So we do a bidigital repeated stretching until a small hole happens. And now we pull the hole up and down, the peritoneum will open transversely. We do not use abdominal pecs because, number one, we will get less adhesions if we do not use pecs. And number two, remember, amniotic fluid do have bacteriostatic characteristics. So if you are cleaning them too well, you might get a higher febrile morbidity. Munro Kerr was a Scot, and he had the idea for the first time to open the uterus transversely in a lower segment. So I'll speak about it a little later. So what you do right now, you just open the plica, you push it down and you open it as low as possible. But lately, some clinicians challenged this idea and they started to open the lower segment above, which is, we believe, wrong. Because in 1830, Müller described the paramesonephric ducts, and as we know, the uterus and cervix are one organ, and the histology and function are completely different. The endometrium has a unique hormonally dependent cyclic pattern, and as you all know from Spinbarkeit and crystallization, and does not function like other sphincters in the body. And this is a very important slide because Rory already in 1967 did a study and found out that the higher you go in the uterus, the more muscle tissue will be found. It means that the higher you make the incision, the more muscle you damage. And I will say that muscle will never become strong again after cutting it, but fibrous tissue will become strong and even stronger than it used to be before. It means that the lower we open the uterus, the stronger the scar will be. So the different histological pattern might have relevance to the site where we open the uterus. Therefore, we are cutting the plica transversely, we push it down, and then we open the uterus below the plica. We even published an article about it, which is called Revision of Embryology Influence the Cesarean section technique. Now, we deliver the baby, and thereafter we exteriorize the uterus in order to prevent, while stitching, damage to the other abdominal organs, to enable manual contraction of the uterus, and also, very important, remember, always look and watch the ovaries. We had one case where we had to open the abdomen again, not to open, we did it endoscopically 4 months after surgery, after cesarean section, due to a 6 centimeters cyst, on dermoid cyst in the ovary, which certainly was 4 months also before, and nobody watched it while operating. So now, stitching the uterus we do with big needle and one layer. Suturing in one layer will make less circulations and will make stronger scars. We don't have now time to explain why some people are writing completely different ideas about it. But you can see here that double layer closure does not increase the myometrial thickness compared to single layer closure. And you can see here how we do it. We are using a huge needle of 8 centimeters in diameter, 8 centimeters. And the reason is that the bigger the needle is, therefore less suture material will stay behind, which means less foreign body reaction, stronger scars, and less post-operative pains. Now, you can see here another study in VBEC of 448 patients. Only 5.2% had uterine ruptures, where the previous one was sutured with one layer, compared to 13.1% if two layers were done in the previous operation. So again, another, well, they're all repeating the same. Now, why other people are writing different? Because the works which they show us are not standardized, and only standardized optimal surgical methods are enabling meta-analysis. Therefore, wherever we find an article claiming that two layers are stronger, we find out that the study was not standardized. About the size, I know it's a very funny title, but this is an article which we published called Does Size Matter? Which means the bigger needle you use, and you can see even that we produce for us a suture a kit for cesarean section with 80 millimeter needles. Now, we come here to a very interesting point. In 1846, for the first time, general anesthesia was used. And suddenly, the doctors, the surgeons, were not in a hurry. They were not in a hurry because now they had time. And this was the first time, the first publication where peritoneum was sutured at the end of an operation. Harold Ellis in 1980 showed us that when you leave peritoneum open, a new one will form within 1 to 2 days from the primitive cellum cells which are underneath the muscles. And if you are suturing, the sutures are providing focal points for adhesions. In 1979, 80, I was working in Newcastle Tyne. I was doing my oncology. I went all the way to Harold Ellis in London at the Westminster Hospital, asking him if we should also leave peritoneum open in oncological operation at that time. And his answer was, God forbidden, because he was afraid that if you do it in the lower abdomen. Fortunately, we didn't believe him. Fortunately, in 1980, we didn't have ethical committees, and therefore we were able to start and leaving peritoneum open in all operations, including cesarean sections. And here you can see a study from 1993 showing that in the second operation, significantly less adhesions if in the first operation peritoneum was left open. Royal College of Obstetrician Gynecologists in London accepted our concept. You can see already guideline from July 2002. Now, many studies were done like this from Egypt, showing that if you leave peritoneum open, you will get less adhesions. This is another study showing the same, and also an Italian study showing also the same. If you leave peritoneum open, you get less adhesions. So all what we have to do is to close fascia and skin. The fascia is closed continuously. I always suggest to make the first incision to start from inside outside. If you do it this way, the knot will be beneath the fascia, and if it is beneath the fascia, you will not get sensitivity in the subcutis. So here you can see, you continue towards the assistant, and the assistant will lift the two lateral, and then you continue until you get to the assistant, and you make this knot. Now, the skin we close with as few sutures as possible. If you do so, there is a good drainage. You will get less seromatase, less hematomatase, and less postoperative pain and fever. So again, huge, big skin needles, Donati sutures, first one in the middle, and then two lateral, absolutely enough. At the end of the operation, you can put Alice Clem for 4 or 5 minutes, and this how it looks the next day. The lateral one you can already open after 2 days. The mid one you can leave for 5 days. So there's a good drainage, less pain, and less hematoma. Also, of course, there are skin closure with other ways, but if you do intradermal, you have to put more sutures in the subcutis. Now, I don't know, we just spoke about music in the operation room, but we produce a partitur for the Zahn section. You can see here 5 fingers, and if somebody is interested, he can learn here exactly which finger to use in each step, because it makes a big difference. Except the music in the operation room, which I agree should always be done. The Cézanne section I'm talking about was introduced in 1994 in Figo in Montreal. The University of Uppsala took this operation, adopted it at the University of Uppsala, and distributed the method in more than 100 countries. Now, at the moment, this operation as is in use in, I would say, all over the continent. I don't know if Australia, but I don't have information, but all over South America, North America, Europe, Africa. And we did already surgical workshops in 39 countries. Why is such a good acceptance? Number one, because the women are very mobile after the operation. You can see a woman 7 hours after surgery. She can look after her child and she can bend down and touch her toes, just 7 hours after surgery. Number two, they drink immediately. We already published it, it's not new. Of course, also gum chewing, early oral hydration, all these measures are helping. And what we did, as we do many workshops in Africa, we started the All African Surgical Database, where started already only in West Africa, in the French-speaking countries. After surgery, electronically, they complete this form and they send it, and it is evaluated. You can see already the first publication about toward the unified evidence-based design section in African continent. And so we have exactly, we know exactly what are the outcome in each different country. Burkina Faso, which is the poorest country in the world, 95% of all surgeons are using today this method. And very simple, only 10 instruments are necessary and only 3 stitching material. Now, the statistics, I will go very quick over it because it's boring. All are showing the same. There are already over 80 comparative studies between Ms. Gavladach method and traditional method. There is no single publication which found negative, which showed negative results. The average delivery time is shorter, operation time is less, and average blood loss is less significantly. Now, you can see this is one of the first studies which was done at the University of Uppsala in Sweden. Again, less blood, and this is a British publication which shows that all parameters, without any exception, were in favor of this method, even if there were complications. The mobility after complications was certainly significantly shorter than with a traditional operation. Again, it's boring because all are showing the same. This is a study which was done in Africa, in Senegal, showing that the operation time is shorter and the direct costs of the operation are lower. Again and again. So to summarize, the Ms. Gavladach incision was associated with significant advantage in terms of reduction of post-surgical acute and chronic pain, and many other publications about, and a study which Professor Di Renzo and myself participated. It's about the long-term outcomes of Ms. Gavladach method, and so better neuropathic, less neuropathic pains, less chronic pain, and good satisfaction regarding the cosmetic appearance of the scar. we did many workshops all over the world. Here you can see one which was done in China, again in China, in Korea. Here is the in India, and in Africa. You can see here what we did in. This was in Senegal, and this was a study which we did in Burkina Faso with Eric Jandiot, who is now speaking, I believe, in another session. And you can see this was lately, last year, it was in Chechnya. So some publications, here is one in, this one was in American Journal, and I was a little younger, well, and this is a textbook from China about this microstructure cesarean section. But now I have a couple of minutes. I would like to share with you my idea why not to do too many cesarean sections. So together with Michel Audent in my C-section book, there's a chapter, what is the future of civilization delivered by cesarean section? You can see here that the delivery itself is a very complicated, the head is doing all kinds of movements. We heard before, very complicated. We heard before an excellent presentation of the Odon device, which might maybe help. But if you look here very well, this is about 4,500 years ago in Egypt. You can see two midwives are helping a woman to give birth, and she is crawling, she's sitting, she's not lying on, she's not on the bed. And here, again, from Egypt, about 4,500 years ago, the woman is sitting. From Africa, 1,800 years ago, two midwives are helping a woman to give birth while she is sitting. And also, you can see here, the first school for midwives in the 19th century in the United States, teaching midwives to accept the baby while the woman is crawling and not. Now, Isaac Newton, I'm quite sure all of you heard his name. He was, I believe, the most important obstetrician all over the world. Why? Because he described the gravity. So the baby comes down, and today, at the time that the baby was born towards the floor, probably the process was much easier because the head didn't go back between contractions. And today we deliver babies who are going straight to the space. Now, you can see here why is the from our book delivery so difficult? Because on the left side you can see the chimpanzee with a big distance between the head and the pelvis, but Homo sapiens nearly the same size. Therefore, all these strange ways. The reason is that because we are Homo sapiens, we have big head, but because we are running, we need narrow pelvis. The combination of narrow pelvis and big head makes delivery very difficult. So, but lately, many authors support the idea that the woman herself should be enabled to decide what is the risk, as if there is a risk in a normal delivery. And therefore, this comes from Vienna. And therefore, one of the reasons that all over the world, more and more cesarean sections are being done at the moment. I don't want, because I'm certain that we'll hear about it later. So if you believe that this was a way that man was created, fine, you can believe so. But if you believe that there is evolution, like Charles Darwin said, it takes time, millions of years, until we get to what we are right now. And 10 years are very short time, because 10 years ago, we didn't have blue eyes, there was no lactose tolerance, and all of this happened just in the last 10 days. An excellent Cochrane book. So at the moment, we have difference between the masculine and feminine pelvis, because the feminine pelvis must be wider in order to enable the baby to go through. But if we continue to do cesarean sections, so with evolution, it might be that the baby will not stay in the uterus for 9 months, maybe he will be able to stay longer, because today our babies are born premature. The only mammals where we have to look after the baby until it becomes independent, sometimes 20 or 30 years. So if the baby stays in the uterus for longer, and because of too many cesarean sections, the head might become bigger, the pelvis might become a little narrow. So maybe this is how cesarean section will look in many, many years from now, where the baby will be able to cut himself the cord. So in order to avoid too many cesarean sections, we created the anti-cesarean section campaign some years ago, and you can read about it in our website. And one of the measures which we started was to ask always for a written, documented second opinion for any non-emergency cesarean section. In one of the hospitals I was working in France, we were able, just in 2 months, to reduce the C-section rate from 28 to 17%. So this is, as you can see here, non-viscid artery, which means operation is not just work, it is also a part of the art. And therefore, it's very important to do cesarean section in the most optimal way. And we hope very much we are still introducing this operation all over. And we believe that this operation, with time, will become a universal operation to be used everywhere, as is, and in order to get the best possible outcome. Thank you very much.
Thank you very much, Michael. I will do the next lecture now, if you can see my screen. And after this, we'll take questions for Dr. Stark. And if you have for myself, thank you for the ones who are putting the questions in the question Q&A at the bottom. Feel free to put more. Hopefully, we'll have a few minutes to go over those after the wonderful lecture by Dr. Stark. I will also go over quickly intraoperative technique. One of the ideas was to see how much we deferred in terms of technique with Dr. Stark, but we don't defer much at all. So I think actually we're all coming to the same conclusions. He talked about a transverse skin incision. He talked about Joel Cohen, and I want to add to that again, verticals are very seldomly used. I don't remember the last time I did a vertical incision. Only if really a minute difference to deliver the baby makes a difference, you may consider that. And I always say that it's important when you make the incision to make it big enough so that the baby can come through. We have a lot of obese women here in Philadelphia and more around the world. So we just finished our randomized studies on women with a BMI of over 35, comparing Joel Cohen, which sometimes goes actually kind of above the pannus on an obese woman, compared to a phanestil, which would be below a pannus. And we don't have the results yet, but maybe next birth meeting and next year we'll present the results. Then he talked about opening the subcutaneous tissue. I completely agree. It should be done bluntly, as Stark-like as possible. And then the question is to use the scalpel if you have any scarred tissue, or the bovie. And there is a randomized study showing a little bit less blood loss using the bovie. But again, as much bluntly as you can. And also here, you can also open the fascia if you want. Initially, maybe with a scalpel, but maybe if you use the blunt Stark technique, you may also lower blood loss and less time. He didn't talk about it, and I agree, there's probably no need to dissect the fascia of the rectus muscle. There is a randomized study on this as well, showing in brief no benefits. Then again, we do open the peritoneum bluntly, just like Dr. Stark taught us all in the last 30 years. Very easy to do. Again, an incision big enough. It didn't cover it, but sometimes, again, especially in obese women, you may need more retraction. There are randomized studies and this meta-analysis from a couple of years ago on this particular type of retractor, and despite quite big numbers of randomized studies and meta-analysis and patients, and no benefit in terms of the main outcomes of infection and blood loss. Bladder flap, they talked about as well. We haven't done it for many years, and I think in general, we can avoid doing the bladder flap. There actually can be more adhesions and problems if you do it. The uterine incision, I completely agree with him. The lower you do it, the stronger it's going to be. Obviously, the transverse better than vertical, and you can expand it again bluntly and not with scissors. Large Cochrane on that, and also as he showed, you can put your fingers up and down, cephalocaudal, having less blood loss, and especially less extensions on the side, which can bleed, as you know, quite a bit. After the baby is delivered, the placenta can be delivered spontaneously. No need to put your hand inside. That actually, if you put your hand inside, would increase blood loss and infection. So just put some gentle contractions on the placenta, and the placenta can come out spontaneously. No need really to curette with a sponge. I've seen, I'm sure Michael has seen it all over the place. Some people use their hands, some people use a 4x4, some people put iodine. Not much evidence on what to do, but certainly the uterus should be cleaned. And when you suture it, no need to open the cervix, even if somebody has not labored. And if you want, you can use blunt needles if you're afraid of sticking your fingers. He preferred, I think, if I heard it correctly, to exteriorize the uterus. I do as well. The evidence is that the outcomes are similar compared to keeping the uterus inside, but I think it's much easier to repair outside as long as you can see everything. And this is new in terms of preventing postpartum hemorrhage. Large, I think one of the largest I've ever seen in obstetrics, Cochrane meta-analysis, almost 89,000 women, showing that actually we should use something more than just oxytocin. Some places have carbetocin, which works great. Otherwise, if you don't have that, like in the United States, we use either oxytocin or misoprostol or oxytocin or ergometrin. We usually use here oxy and meso, being better, meaning less blood loss and complication than oxytocin alone. It's interesting that many people massage the uterus at this point as well, but there are no randomized studies showing that that's really beneficial. And I would suggest for the young ones and the passionate ones on this that you do that randomized study would be interesting. If we're tying the tubes, we definitely close the uterus in one layer, and Michael, I think, showed that you can do it continuously. We do not lock. There was a question on that. We do not lock. Some data is shown, especially from Canada, that locking may weaken the scar, causing ischemia. And so we do not lock, and we do full thickness, which seems to be associated with a better postpartum ultrasound scar incision. But again, we need more data on all this. And we certainly, while the short-term outcomes are better with a single continuous closure, and the long-term outcomes we really don't know. And we must admit that in patients that do not have a tubal, are young, and are planning a bigger family, we sometimes consider doing double layer. There's a large randomized study on using adhesion prevention, which showed no effect. No need to do irrigation. Again, Dr. Stark didn't talk about this, and I agree with him. It doesn't need to be done, and the appendix can be left alone unless it's obviously abnormal. We do not close the peritoneum, and we agree on this as well. Short-term benefits of keeping it open, and even long-term less adhesions, as you said. We close the fascia. This is a really important step, and it's questionable if to do it in smaller bites compared to bigger bites. This is a Lancet large randomized study in non-pregnant adults showing smaller bites are better, but we really don't know. We don't close the sub-Q in everyone, even if I think we need more data on this, but we do close it on women that have 2 or more centimeters of fat, because again, this randomized studies in Cochrane show less wound complications. So many women are obese, have more than 2 centimeters of fat, and we close the sub-Q with sutures. We do not put drains in, and Dr. Stark did not talk about this because he doesn't do it, I'm sure, and no benefit from routine drainage. The one thing we may defer is how we close the skin. He did it with sutures, but interrupted kind of perpendicular sutures to the scar, while we do it with sutures kind of sub-Q. And this is because of a randomized study that Dr. McKean did here at Jefferson, and then Cochrane and meta-analysis showing less wound complication, better satisfaction, and better cosmesis using sutures compared to staples. So we don't use staples anymore. Here is the meta-analysis with 12 randomized studies and over 3,000 women, again showing less wound complications and with sutures. So after deliver the baby, I was going to cover the second part of my lecture real quick will be on post-op care, post-cesarean care. We talked about giving some gabapentin maybe before even the C-section. We do around-the-clock NSAID and around-the-clock acetaminophen, which decreases pain scores, and you can decrease also narcotic use, either IV or oral. Good evidence, many randomized studies on around-the-clock NSAIDs and acetaminophen. We talked about gabapentin. You can also use lidocaine TAP block, randomized studies showing benefit, and epidural morphine also showing benefit. Everything to avoid giving opioids by mouth or by IV. All of this increases patient satisfaction and decreases pain. As I said, you can avoid the Foley, but if you don't, you can actually take it out right away. Again, level 1 evidence that the patient does better, including walking sooner and going home quicker. They can ambulate pretty quickly. Dr. Stark showed us a beautiful lady walking and bending 7 hours after surgery. And again, if you do it correctly, women, even 4 hours after cesarean delivery, can quickly walk and have major benefits in terms of intestinal recovery and less risk of venous thromboembolism. You can also chew gum, as he touched on, and there's a large meta-analysis showing quicker recovery of the patient if she chews gum 3 times a day for 30 minutes. There's less nausea, vomiting, less ileus, and also higher patient satisfaction. And as they get to passing flatus, within 8 hours even of a C-section, you can feed them. So they can ambulate quickly, they can chew right away, and they can begin eating as they tolerate. Again, a large meta-analysis of data. The bandage, I'm not even sure is necessary. It'd be interesting to know what Michael does. We don't know what kind of bandage is best, but in terms of keeping it on, we don't need to keep it on much. You can actually keep it on just 6 hours at most. Patient does better and it's more satisfied if you take it out at 6 hours compared to 24 hours, as per this meta-analysis in the gray journal. You can obviously start breastfeeding and skin to skin right away. We all know the benefits of that and rooming in. And you can also insert a large contraception at C-section. It's very effective. And while the expulsion rate is not low, many of our women do not come back at 6 weeks postpartum or 4 weeks postpartum. And the best chance of actually giving them long-term contraception is to place it during the C-section. They can pretty much start normal activities right away and use their common sense for climbing and lifting. But certainly we recommend starting back on exercise and regular activities pretty quickly after C-section. And now, especially with COVID, we send them home maximum day 2, sometimes even day 1, and there's evidence that this is safe. Again, we try to, even today I rounded in the hospital a couple hours ago, and we do have still COVID positive patients, usually mild cases. And so we want to send patients home as soon as safe. So to summarize, I think Dr. Stark and I agree a lot. I did talk about this, the use of music, family-oriented and skin-to-skin C-section earlier on. The use of tranexamic acid in many C-sections, especially high risk before the C-section, and then using 2 agents as soon as the baby is delivered to decrease postpartum hemorrhage. We talked about blunt encephalocaudal uterine expansion and post C-section using around-the-clock acetaminophen and non-steroidal medication, such as ibuprofen, or there are many other ones that you can use, using TAP analgesia, epidural opioid analgesia, which altogether, all this decreases the use of IV or overall opioid use. A patient should chew as soon as the C-section is over. That will increase their GI, gastrointestinal function. They can ambulate right away at 4 hours. The bandage can be removed 6 hours, and they can eat at 8 hours. So quickly recover, and as I say, they can go home even a day or 2 after C-section. So that's my quick intra-op review. Agrees very much with what Dr. Stark as discussed, and post-op review, lots of wonderful evidence. Maybe, Michael, if it's okay with you, I can ask you some of the questions that have been put in the Q&A. Is that okay?
Absolutely.
So let me see. Or you answered some of these already. So do you, after incising the uterus in the midline, pull longitudinally or transversely?
Always transversely, of course. The incision in the uterus in the lower segment should be done transversely, and as I said, low as possible, in order to less damage to muscle tissue.
And do you recommend excluding the endometrium while suturing or not? That's very controversial.
This is frequently asked, and until now we are including the endometrium. We are including the endometrium with a suture because after 9 months of extensive progesterone, let's say dose, there is no chance for let's say endometriosis, for let's say for transplanting endometrial cells into the outer part of the uterus. Therefore, we take the whole layer together with the endometrium.
We do the same, so we agree on that as well. That's good.
I just want to add, because somebody asked about the, or you mentioned also about the locking or unlocking.
Yeah.
I didn't have, I had only half an hour. I didn't have time to go into other small details, like, for example, what do we do with the blood clots, etc. We'll get, maybe somebody will ask, so we will get to it later. However, the uterus starts contracting soon after the delivery. Already after a couple of hours, it is losing of its volume, and 6 weeks after surgery, it will be back to the original size which it had before we started the operation, or before we started the pregnancy, which means that uterus contracts. The sutures cannot contract together with the uterus. So the aim of the uterus, the aim of the sutures is just immediate hemostasis. And the hemostasis happens by contraction of the uterus. The contraction itself makes the hemostasis. Therefore, if you are locking or unlocking, doesn't make any difference, because few hours later, anyhow, it will be loosened above the opening. I can't hear you.
So
you were,
here I am. So we do not lock just because there were some data from Canada, I think Dr. Bujol and others, that there could be more incidents of uterine rupture sometimes with locking. It's retrospective data, so I'm not sure it's correct, but that would be the only possible reason.
Yeah.
They ask, if you do a C-section at 25 weeks of pregnancy, do you perform a longitudinal uterine section?
Never ever. Never ever, except for, let's say, if you do it in the 27, 28 weeks, that's something that's different because you don't have the lower segment. So you have to do it longitudinal incision. If you do a C-section in 28th week, otherwise it will be very difficult to get the baby out. But normally, after 32, 33 weeks, always transverse incision.
Right. Let me see, suture choice for uterine closure, monofilament or braided suture?
Honestly, it doesn't make any difference whatsoever.
And there are a couple of randomized studies I know in the US, and really it's interesting, Michael, 30 years ago you devised all this and there was not too much data, but there was a lot of common sense and a lot of personal experience. And the data has absolutely, confirmed, your opinions. And I think in terms of suture, I agree with you. I don't think it makes much of a difference, but I think we need to study some more. The next question here is why better.
Just a small remark. The most important is not which kind of suture you're using, but what is the amount, which means that the less suture material you leave inside, the better will be the outcome. Therefore, we are using big needles, and we are trying to do only one layer, and we are using these big needles in order to have less suture material left behind.
Yeah. I'll answer quickly the next two questions. You can surely chime in, Michael. They asked why better oxytocin and misoprostol or carbetocin. As I showed before, that was based on Gallo's big Cochrane review. It was a network meta-analysis, and I think it was pretty convincing that you should use something. You should use oxytocin if you have it, but better than oxytocin is carbetocin. And if you use oxytocin, you may want to add either misoprostol or ergometrin, and that's what the data shows. Again, postpartum hemorrhage is still a big issue, and that's important.
I agree.
And then the transparent cover towel that the patient can see baby coming out of the belly. Yes, we do that. As I say, that's kind of part of the family-friendly C-section. So that's routine for us. Actually, both the mother and the significant other can go and see the baby as the baby comes out. The next one, I'll have you answer. They say, what is your opinion, this is from Panama, about the French ambulatory C-section? They quote an article from 2007.
The French ambulatory cesarean section is repeat on something which was used 60, 70 years ago, the extraperitoneal operation. Now, I had the opportunity in 2 conferences in France to hear about it. It comes from Paris, and what they do, they are trying to open the uterus. So number one, and they claim that the mobility is quicker, and they claim also that there are less pain after operation. For the pain after operation, honestly, I've seen the publications, but I cannot accept it because, again, if you don't compare it to, let's say, they say that they compare it to Misgavradach cesarean section, but the details are completely different. And number one, number two, I believe his name is Ami, the one who published it. He confirmed that he had a couple of bladder damage, and the time to take the baby out was about 6 to 7 minutes. So why and this method is, as I said, it's French ambulatory, but it was used 78 years ago before the antibiotic, before the use of antibiotics. I believe, and number two, we are looking for a cesarean section which will be able to be used everywhere universally by people who are even minimally trained, because the operation is very simple. And you know, to go back to the extraperitoneal, I believe it's absolutely wrong. And therefore, I'm very much against. Today we have antibiotics. The rate we give prophylactic antibiotics, the rate of infection is anyhow very, very minor after cesarean section. And if there's a, let's say, the etiology is not necessarily by opening the uterus. It can be, the etiology can be also something which happens in the subcutis or in the skin incision. And therefore, I don't see any point today of using the new French ambulatory. And I say it very loudly, you can quote me.
Thank you, Michael. We have a lot of other questions, but I think we want to make sure we finish on time and we give time to the next speaker. I guess I'll ask you one last question real quick, though, less than 30 seconds. Michael, do you recommend uterine cavity curettage after delivery of the placenta?
Absolutely not. Absolutely not.
Good.
Unless, I mean, you can use a boom curette in case that you have a creta or percreta and you want to avoid a hysterectomy. But never use a curette. It makes a big damage, and you know, and if the placenta is separated spontaneously, as God designed the uterus, there's no reason whatsoever. Also, after normal delivery, you don't put a curette inside.
Great. Thank you, Michael. I think I enjoyed that session tremendously. I hope everybody else did. So I'll pass it on to the next speaker. I think Rasha is on, Rasha Kamel, and she can share her screen and take over and talk about the impact of cervical dilatation on the location and integrity of the cesarean section scar. And Michael, you can moderate, you know, the rest. Feel free.
Okay.
Thank you for having me again.
Thank you, Mr. You are mute right now.
Yes. I'm just trying to share my screen. Is it there already? Maybe not.
You have to push on share screen.
Yes, I did. Am I allowed? Did the host allow me to share my screen? Ah, there it is.
Yeah.
Okay. Well, first of all, I'd like to wish you all a good afternoon, and I wish you're all keeping well within the current COVID situation. I would like to start by thanking Professor Dorenzo and Professor Romero for their kind invitation. I would also like to thank the previous speakers for such a very good session and very, very informative talks. So I would like to present our last published study. It was published in the White Journal. It was about the position and integrity of the uterine scar as determined by cervical dilatation at the time of cesarean section, and therefore the impact of cervix dilatation on the cesarean scar. This was a collaborative study between our unit in Cairo University and in St. George's University Hospital and Nottingham University Hospital. So as we all know, and as been proved by lots of recent studies, abnormally invasive placenta is more common after an elective cesarean section. And this suggests that pre-labor cesarean section increases the likelihood of a scar being above the internal cervical os, predisposing to a future scar pregnancy. And therefore, we conducted the study aiming to assess the location and integrity of the uterine scar in postpartum women who delivered by cesarean section at various stages of labor. So we recruited 407 women. This was a prospective cohort study. We recruited 407 women undergoing a first cesarean section at term. 103 of those had their cesarean section at a cervical dilatation of less than 2 centimeters, which means either they were not in labor or very early in labor. 261 women had a cervical dilatation between 3 and 7 centimeters, and 43 women had a cervical dilatation equal to or more than 8 centimeters, which means they were rather late in labor. The decision as to who will deliver by cesarean section and the timing of cesarean section was made by the attending obstetricians, who were of course blinded to our study. We had all these patients come back in for a transvaginal examination 3 months postpartum, and we aimed to locate the cesarean scar in relation to the internal cervical os, and also we were looking for uterine scar niches. So these are our results here. We have here the patients in the 3 groups. This is the group 1, which is elective cesarean section group. The cervix was less than 2 centimeters when they had the cesarean section. This was the second group where they had the cesarean section at a dilatation of 3 to 7 centimeters. And this is the third group where they had the cesarean section at a cervical dilatation of 8 or more centimeters. As you can see here, the birth to assessment interval was not statistically significant. They all came around 3 months later for the transvaginal examination. But what was really strikingly significant was the location of the cesarean section scar in relation to the timing of the cesarean section. You see here in the first group, in the elective group, out of 103 women, 100 women had their scar or niche present above the internal os, which means 97% almost. And in group 3, with a cervical dilatation of 8 centimeters or more at the time of cesarean section, out of 43 women, 42 women had their cesarean section scar or niche below the internal os, which means almost 98%. And as you can see here, the distances, we measured the distances, the corresponding distances are displayed here in the bottom row. These are the distances of the scars or niches from the internal os. And you can see here, this is the average. In group 1, it was an average of 9.8 above the internal os. In group 2, it was an average of around 3 centimeters above the internal, 3 millimeters, sorry, above the internal os. And in group 3, it was either opposite to the internal os or below, and this is why it's presented here with a negative value, which is minus 1.4. And of course, these were all statistically significant. When it comes to the niche, well, when we analyzed it as regards the timing of a cesarean section in relation to cervical dilatation, it was not really significantly different, the presence of niches or the development of uterine niches between the 3 groups. This is here how we did the examination, and this is a display of our results. We got a longitudinal image of the uterus, and we measured the distance from the mucosal edge of the scar to the internal os. And here, this is the first group where they had the cesarean section scar above the internal os. As you can see here, is the internal os, and the mucosal edge is way above the internal os. And here is the illustrative image that corresponds to the ultrasound image on the left side. And here, this is sorry. Something wrong with the video. Okay. Here is the group of patients who had their scars below the internal os, and you can see here the difference. The internal os is here, and the scars are way below the internal os, and we always used the mucosal edge of the scar as our landmark. Of course, the internal os was demarcated by the end of the cervical canal. Both ora, the external and the internal os of the cervix, were identified as, according to the ISO guidelines and according to the latest publication by Kagan et al., the external os is identified by the meeting of both cervical lips externally, and the internal os was identified by the end and the transition between the cervical canal and the endometrial cavity. This is, there was a slide that got jumped here. I think this is it. Yes, this is the group of patients who had their scar exactly opposite to the internal os, and you can see again the difference between the location of the scars between the 3 groups. Okay, as regards the uterine niches, the presence of uterine niches were also assessed. That was one of the targets of the postpartum transvaginal scan. And as we know, the niche is defined as this anechoic defect here. That is, it's a defect in the myometrium in the cesarean section scar, and it's communicating with the endometrial cavity. And we assessed the presence or absence of those niches in the different patients, and we also assessed the distance of those niches to the internal os. There was no statistically significant difference in the development of niches between the three groups based on cervical dilatation at the time of cesarean section. But when analyzed by position, uterine niches were observed in 38% of the scars that were above the internal os, compared to 17% of the scars that were at or below the internal cervical os. This is a graph here that shows the correlation between the cervical dilatation at the time of cesarean section and the distance between the uterine scar or niche to the internal os of the cervix. And you can see here, the larger the cervical dilatation at the time of cesarean section, the closer to the internal os or further down into the cervical canal the scar was, and vice versa. So we concluded that cesarean sections that are performed pre-labor or early on in labor are associated with increased prevalence of scars in the uterine cavity, and also more associated with uterine scar niches, whereas the cesarean sections that are performed late in labor are associated with or are more associated with scars in the endocervix and fewer uterine scar niches. So this would lead us to the conclusion that position and integrity of the uterine scar after pre-labor and early labor cesarean birth explains the predisposition to abnormal placental invasion in a subsequent pregnancy. And this is, of course, what concerns us the most as obstetrician regarding, of course, the increased prevalence of abnormally invasive placenta nowadays. Thank you very much.
Thank you very much. Dr. Kamel, it's a very interesting information, and but my question is, what is the let's say, it's an outcome of this study? How will you deal with the cesarean section in the future, if it's at the beginning of a delivery or with 7 or 8 centimeters? Will you have a different different attitude? Will you open the uterus in a different level, or?
Yes, well, we are promoting, as you yourself had promoted in your previous talk, of course, the lower the uterine scar is, the better. The other thing we have to think of is the question of the elective cesarean section. We have to revisit this decision. The elective cesarean section has to be revisited. We have to balance the pros and the cons of elective cesarean section. Of course, there's the convenience part, there's the cost effectiveness part of an elective cesarean section, but we have to weigh that against the possibilities and the risks of having a scar that is high into the uterine cavity with the possibility of increased prevalence of uterine niches. And of course, those two factors are going to have an increased predisposition to an abnormally invasive placenta.
It's an excellent presentation, but only one question. What is your routine? Where do you open routinely the uterus?
Where do we open routinely the uterus?
Where do you, I mean, in which level you open the uterus routinely?
Well, it depends. Well, again, it will take us to my study again, because it depends on which stage of labor the patient we are performing the cesarean section. If it's an elective, we always advocate the lower the better. Of course, if it's in labor, if the woman is presenting an obstructed labor or far down or far into labor, then of course we're going to have a well taken up cervix, and it's going to be low, preferably. But the question is also always when it's an elective section or early on in labor. So we always advise the lower the better. Nice. The coaptation of the layers is much better. The liability for adhesions is much better now. With this study in the background, again, this just reinforces this recommendation. Yeah.
I'm certain that Dr. Bargela and myself, we agree with you totally about this point.
We do.
Yeah,
we do.
Maybe do we have time for more questions? Or yes.
So we have one more presentation, 5 minutes presentations on Lithuania's 80-year experience in reducing C-section. If the speaker is on, she can share the screen, and she has the last few minutes. Thank you. Thank you for joining us. And then we need to
She's
finish.
She's also our representative in her country.
Hello, I want to share the screen, but hello, but somehow not.
Ruta, sorry,
Yeah.
it's Natalia. You're sharing. You just need to put the presentation in the slide mode.
Okay, so it's okay now?
Now we can hear and we can see. Yeah.
But you can see?
We can
Yes.
see the presentation.
Okay, very nice, very nice. So, first of all, I would like to thank Professor Direnzen, for Professor Romero for conducting such a great Congress. And of course, thank you both chairman for the excellent talks and the lectures. And of course, previous lecture, it was really, really interesting. So I would like to share how we managed to decrease cesarean section rate in Lithuania with a systematic, multifaceted approach, and to show our cesarean section rate in the whole Lithuania, and to show perinatal mortality in this period. So this multifaceted intervention was started in 2012 with national implementation of Robson classification. In my opinion, the most important intervention, it was our success to introduce certain limits of cesarean section rate for different level of maternity care institutions as a quality care indicator. So after national discussion of specialists, we decided that in maternities with low risk deliveries, cesarean section rate should not exceed 12%. In regional hospital, multidisciplinary hospitals, it should not exceed 20%. And in perinatal centers, tertiary referral centers, there are two of these centers, not exceed 25%. The third intervention was national professional training courses of advanced life support in obstetrics for obstetrician gynecologists, and basic life support for midwives. And what is the again very, very important, regular audit at least 2 times a year at the National Committee of Integrative Perinatal Care. And what is important, that the results of this audit are published in our professional journal. They appear in our society website, and all top managers from hospitals that have maternities, they receive the data. So what are results? You can see that in 2012 in perinatal centers we had about 30% of cesarean section rate, and now after this 8 year we have 22 and 23%, and I must say it was not an easy task to achieve this in a multi-profile, multidisciplinary hospitals, regional hospitals. We call this second level hospitals. We started with the 28, 26, 30% of cesarean section rate, and in 2019 most of these hospitals achieved amount of 20% of cesarean section rate. And in the low-risk deliveries maternities, in small maternities units, again, you can see that in 2012, in some of them, there were 27, 28%. But now it's we see good results. Of course, there are possibilities to improve, and I would like just to show that we have only one private maternity, and you can see that in this maternity cesarean section rate is 40%. 40%. This year they decreased in 15%. So it's again good news for the patient who choose to deliver in this maternity. So to conclude that in 2012 we saw that we are at the really threatened beginning of epidemic of cesarean sections. So our systematic, multifaceted approach, we think it was it gave good results, and now we are achieved 20%, and perinatal mortality is about the same. We have a promise from the sick fund. They are going to give some bonuses, some money for those hospitals that follow recommendations and achieve the recommended cesarean section rate as a quality of care indicator, but still we didn't receive this. So we hope that in nearest future it will be reimbursed for those who are really keeping good quality of care in their centers. So thank you.
Thank you. Thank you so much, Ruta. It's nice to meet you here, and I wish that other countries will follow your. Will follow this way and reduce the rate of unnecessary cesarean sections. Very good results, very nice results.
I think if I can say one thing and kind of summarize our thoughts, it's really important to look at the C-section rate and decrease it to a safe level, but it's extremely important also, like you did, to look at perinatal outcomes, maternal perinatal outcomes, because we want to keep the baby outcomes as good as possible while having a C-section rate that is not too high. So important to look at both and seeing that both are trending the right way. So congratulations. I think, Michael, you can probably close the session since it's 4 o'clock.
Yeah, I believe it was, I guess we'll be able to meet afterwards, but in the lounge. But it was really very interesting. I can read, unfortunately, we cannot respond to all the questions and answers because the time is time limit, but I hope that most of the questions were answered, and it was a great pleasure to meet all of you here, and I hope that we'll have many other opportunities to meet in the future as well, and thank you so much, and we conclude our session. Thank you very much.
Thank you, sir. Bye-bye.